I am Abhishek Singh. I'll be doing the micro-ultrasound guided trust biopsy.
Oh, okay.
Yeah.
Are you ready to this?
Because I have said
Like initially you slowly opened the
थोड़ा गेम बढ़ा This is one starry sky.
the report placement what you placed was very interesting and new. Yeah.
So the right side, and now the left side. This you see now the center. No, you are more center like center patterns की बात है. Now this is like a primus area, and then you see starry sky on that side. Yeah, that's the starry sky.
So this is what I meant.
This is peripheral. So the lower side of the screen.
With the micro-ultrasound guided biopsy by Dr. Abhishek Singh.
Right.
We now hand over to Dr. Abhishek Singh. Sir, please go ahead.
Okay, am I audible at this point?
Yeah, you are audible, Dr. Abhishek.
Yeah, good morning.
Very good morning, Dr. Bejan here.
Good morning, sir. Good morning. So, sir, I will try to demonstrate a micro-ultrasound guided transrectal biopsy today. As you would have seen, this is a 73-year-old gentleman with a PSA of 13. He has some comorbids. And what they have reported on MR is that there is a pyrite 5 lesion in transitional zone.
Yeah.
Now, if you look at the characteristics of MRI, the peripheral zone looks quite compressed. And this is, the findings are more of a benign disease rather than malignant.
Absolutely.
When you have on an MR, when you actually have a pyrite 5 lesion, the sign typically is called a charcoal erase kind of a sign that you see. Nonetheless, we will try to decipher the findings of a micro-ultrasound scan and then subsequently do biopsy. Sir, is my ultrasound view visible to you?
No.
Okay, so can we have the ultrasound view, please?
Yeah. Now it's visible.
Okay, so sir, this is my probe, and I'll show you the probe once I'm done with the procedure. So the only natural array that you get in a micro-ultrasound is the sagittal view. Okay, at this point I have a 50 mm view, and during the course of the lecture I'll tell you the details and significance of what views, how to do it. But at present it is a 50 mm view that covers the whole prostate. And now I'll just show you the urethra. This is I'm working at the apex at this point.
Yeah.
So now the urethra will come into view. You can see the rising urethra now. Can you appreciate to the screen?
Yeah.
So,
But in the middle of the
yeah. So this is my midline.
Yeah.
Now I move inside onto the midline. So I see the prostate. Now you can very well say a demarcation of the capsule. So first try to identify the capsule all around. So that is the prostate, and now you can see the differentiation between the transitional zone and the peripheral zone. So this is, I am moving towards the left of the patient now to give you a complete sense of scan, and then I will slowly move to the right. We are not discussing anything at this point. We are just scanning the patient. And why I am doing this scan? Because the grayscale that you are used to is a smooth grayscale. And I'm sure the audience is wondering that what this dirty grayscale has come now, it is of no value. And I realized that the first time you look at this, you all, I also thought that this grayscale is really dirty. And it does not it does not align to our ascribed beliefs at this point. Okay, sir.
Okay.
Now again, I will in the center you see some dark patches.
Yeah.
Yes, sir. These are normal ductular patches. Okay. The magnification of micro ultrasound goes to 70 microns. So when a single ductule is about 120 to 150 and can range up to 250 to 300 microns.
Okay.
So when you scan up to 70 microns, the details of each ductules can be visualized.
Yeah.
Okay, sir. So now again, sir, you again see to the right end of the screen, you will see some ductular patterns. So that means you see small black area, interspersed, and these are normal ductular patterns. Below at 6 o'clock, you see a compressed peripheral zone. Okay, sir.
No.
And now you see at the apex, at the level of the apex, you see some hyperechoic area. Do you see that?
Is it type?
Hyperechoic, multiple small dots. Do you see it?
Yeah.
So that you call as a starry sky appearance.
Okay.
So that corresponds to primus 4 lesion. Now micro ultrasound has a grading of its own, and like Pyrad's grading, this grading is called the primus grading from 1 to 5. And works on the similar principle that grade 1, 2 are totally benign and 3 to 5 merit a biopsy and 3 is equivocal. So what we are seeing on the apex at this point is between 3 and 4. The starry sky is clearly primus 4. Okay, sir?
Okay.
So I am going to put a target here, a targeted biopsy here. And now keep following me, and you see this lesion, a hypoechoic lesion at the base and some fluid moving inside. Can you see the fluid?
Yeah, we can appreciate that.
So this is the beauty of this machine, that the magnification is so much that you can see the fluid moving inside the ducts. So this also I will put it as primus 3 lesion, and then I will keep scanning.
Good morning, Dr. Abhishek. This is Dr. Vikram.
Morning, sir.
As I see, you are moving the probe to the left of the patient. This one right now?
Now I am moving to the right of the patient.
To the right.
So this is, sir, I am unlike the conventional VK probe, you can't lever this probe. It has to be clockwise and anti-clockwise. The levering of probe, like we in VK, we can lever it on the anal verge up and down and rotate it clockwise, anti-clockwise. This probe has to be moved only clockwise and anti-clockwise.
Alright.
Sir, now at the center of the screen at 6 o'clock, again you see a hyperductular patterns with some interspersed hyperequosity.
Okay.
This I will regard as primus 3. Okay, sir.
Okay.
So, sir, first what I will do, I will take a few targeted biopsies. Is it the most the starry sky that we are seeing from there, and that will take target, and from few nodules that I see primus 3. In my mind, this is a benign gland, but we will see. Okay, sir.
Okay.
So I will increase the depth to 30 now for a biopsy. Please put the biopsy mode on.
Sir, how much is the magnification, more magnification compared to the regular BK what we use?
So the BK, you will get about 3 to 4 times more magnification in this.
Okay.
Okay.
So, does this just have biplanar mode?
It doesn't. It can give you a reconstructed biplanar mode, but necessarily you have to do everything in the sagittal.
Okay.
Okay. Okay, sir. So I will do the first targeted biopsy here from that area that you see. You just stand in front of me, na? Stand in front of me. So this is my first target. As I told you, the starry sky appearance.
Okay. You can see there.
Yeah. So you see big dots and small dots. 2 big dots are separated by a centimeter.
Okay.
Okay, so this is my first this thing.
Sir, Abhishek sir, and meanwhile we'll go to the other OT, the Ganesh Gopal sir OT is ready, we'll just shift there.
Yeah, just see this target and then you can go there.
Okay.
Just see this target.
Sir, they're watching sir, just we'll present the other OT.
Okay.
Case.
Please go ahead. Please.
Yes.
Abhishek sir, your mic on, sir.
Okay, so you see a targeted nodule at the mid side of my screen. This is the nodule that you see. This is
Yes.
mostly a benign nodule. So I have done the right side. I am waiting for you to show the left side. And now please be with me for 2 minutes so that I can show you all the targets. So this is the benign nodule. This is the nodule that I am targeting, and so my needle went through that nodule. I'll take 2 from this target.
Yes.
I'll take
this
one
is-
more, and then I will do the so initially I showed you one target. This is the second target. So 2 I have taken from this. One more I will take.
How many you take it from the other side, of course?
Systematically I have taken 6.
6. Okay.
2 from two targeted.
Okay.
And 3 targets from this. Now I will do systematic on the left. So again, see, this is midline. How I am telling midline? Because the angle here it tells me. Without seeing the urethra also, the angle tells me. Okay. Now you can see the seminal vesicle. Okay, so I am near the midline at this point, at the base of the prostate.
Okay.
So this is the
Yeah, we can see the needle coming.
yeah. Sir, good morning, sir. Sir, sorry, sir, I could not hear you.
Volume.
So, sir, I showed you when I took targeted biopsies, I showed you a lesion which was primus 3. In my mind, that is benign, but that
calcification that angle.
yes, sir. So the calcification that I saw earlier, I took a target from that. So in this, the calcification is called the starry sky appearance, which corresponds to primus 4 lesion. That was at the apex. Sir, at the below the my mark, present mark, can you see another mark, another trajectory of a biopsy? You see that black trajectory of my biopsy?
Below.
Yes. So, sir, that is also very good thing. You can see trajectory marks. Sorry, sir. Please go ahead with your question.
If there is a calcification like peripheral calcification,
Yes, sir.
this high ultrasound, does
Yes.
it interferes with the lesion? Suppose if there is a where the needle is entering, suppose if there is peripheral calcification, it shows a lot of shadowing effect because normally in ultrasound you will see that the calcification hinders.
So, sir, here the grace, it is one of the diagnostic criteria for this machine. So, you see this calcification at the apex. This is starry sky appearance. So, this corresponds to primus 4 actually. And but if there is a to answer your question, if there is a calcification between peripheral zone and the transitional zone, that calcification you can see, but the acoustic shadowing is not terrible.
But
It's not
in this the ultrasound, the diagnostic value is with the calcified.
Yes, sir. This is one of the diagnostic features. So, sir, this was my apex medial,
yeah.
and now this is my apex lateral. So, when I come to the this one auditorium in the lecture, sir, I can show you the patterns. Sir, another thing is that when we want to target the anterior zone, so this is the apex. I compress the gland and then I can swirl and go to the anterior side, like in any of our other machines. And anterior lesions can also be perfectly targeted.
Have you tried the transperineal with this?
Yes, sir. I have tried the transperineal with this. It is also very, very good.
Because the resolution is so excellent.
Yes, sir.
I think probably the transperineal is.
Sir, actually, it is only one of the companies across the globe which has both transperineal and transrectal in single probe. So it is very good, sir. Sir, I could do the anterior lesions.
Yeah.
So, sir, I took 6 systematic 3 targeted on the right side, 2 anterior on the right side, on the left side 6 systematic, 2 targeted from the apex. So about
That should
18,
be okay.
18 odd by,
That should be okay.
So that should be good enough, sir. So I can just show you the probe, sir. So this is the array, linear. All the probes are arranged in a linear array here. They are quite densely packed, and this angle is got. The probe is slightly heavier than the conventional BK probe. Can you please give some perineal compression? It is heavier than the this thing, but the design of holding is quite ergonomic. So, sir, we all might be interested in a straight comparison with BK because we all use it. So, sir, but if I talk about the advantages, the resolution is definitely better, but it has some learning curve. You have to get used to the different kind of a grayscale. You cannot get a triplanar imaging in this. You don't have an end firing approach, but your ability to target the anterior zone is very good if you go far lateral and towards the apex. And if you pull your probe out, then you can see the anterior zones and also identify the lesions. So, I will discuss it in a while, sir.
Sure, no problem. Thank you. Good.
Thank you, Dr. Abhishek. This is a very good demonstration.
Thank you, sir.
We will go to the next topic. Dr. Manish Gopalakrishnan. Yes. You can see a nicely tapered.